Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling gestational diabetes. As always, let's kick it off with a practice question. Save what you think the answer is for the end of the episode, where we'll go through it together. We have a nurse teaching a 30-year-old client at 28 weeks gestation who was just diagnosed with gestational diabetes mellitus, GDM for short. Which statement by the client shows a correct understanding of this teaching? We have A, once I deliver the baby, I won't ever need to check my blood sugar again. B, keeping my blood sugar in the target range can help prevent my baby from getting too big and having low blood sugar after birth. C, I should avoid exercise during pregnancy so my blood sugar doesn't drop too low. Or D, because I have gestational diabetes, my baby will probably be small and need extra growth scans. Again, think it over, tuck it away, and we will circle back at the end of the episode. But first, we need to zoom in on what pregnancy does to the body, even before diabetes enters the chat. Okay, pregnancy is basically a 9-month metabolic stress test, and I feel very qualified to tell you this as I am currently 28 weeks pregnant as we record this today. And your body is growing an entirely new human, which means the demand, that metabolic demand, is going to be high. You need glucose, you need energy. That demand is constantly rising to build said new human. Now, to keep up, mom's body has to carefully balance two big priorities: giving enough glucose to the baby so they can grow, while still keeping her own blood sugar in a safe range. And the placenta is really the star of the show for that. It is an endocrine powerhouse that produces several hormones. These substances all have one major effect: they make mom more insulin resistant. That is especially true in the second and third trimesters. So that would be like 13 to 28 weeks and then 28 to 40 weeks, second and third trimesters. Insulin resistance is going to mean this: the locks on the body's cells. Remember, we think about the cells are locked and insulin's the key, blah, blah, blah. Well, those locks become rusty. Insulin is still the key there, but it has to work much harder now to open that door and get glucose inside the cells. Early in pregnancy, mom's actually a little more sensitive to insulin. That's while the placenta is still forming in the first trimester. But as the placenta grows and those hormone level rise, the body intentionally becomes more resistant to insulin so that we keep more in the bloodstream and therefore send more to the baby. Glucose goes across the placenta really easily, but insulin does not. So the baby's blood sugar is basically mom's blood sugar. And in a typical pregnancy, the maternal pancreas is going to step it up and produce more insulin to overcome that resistance. Our locks are rusty, so we need to make more keys. Resistant to insulin, make more insulin. So even though the cells are kind of, ignoring it a little bit, it got a little rusty, the body just makes more, and that will keep glucose in a fairly normal range because production is ramping up to meet the resistance or match that resistance. So that's a normal pregnancy. What happens in gestational diabetes is that we don't compensate enough. So either the pancreas cannot secrete enough insulin, or the insulin resistance is so strong that even when we make more, we can't keep it in check. That is the blood sugar. We cannot keep that in check. And that results in hyperglycemia, high blood glucose. It is first recognized during pregnancy, usually between 24 and 28 weeks, when we do something called the OGT, Oral Glucose Challenge Test. We'll talk about this more a little bit later, but this is where we give mom some glucose, we check her blood sugar, and we see how she responds to that glucose load. All right, so if we do have gestational diabetes, what does this mean for the baby at a cellular level? Remember, glucose is going across the placenta freely. Insulin, not so much. So whatever sugar is in mom's blood is going to be in baby. And if mom's blood sugar is consistently high, baby is just baking in extra glucose. The fetal pancreas will respond by cranking out extra insulin to deal with that sugar. Yes, the fetus makes its own insulin because insulin not so good at crossing the placenta. And insulin, yes, it's going to help unlock those cells, get the sugar inside, get the blood sugar down so baby, keeps up a normal blood sugar, but insulin is also a growth hormone. So, high fetal insulin plus high fetal glucose means a very well fed baby that's going to end up being real big. The biggest complication of gestational diabetes is macrosomia. That is a big baby. That means a baby over 4,000 grams, or that is 8 pounds, 13 ounces. Now, what else do we think about when we have a big baby? We worry about delivery and an increased risk of shoulder dystocia during delivery. They're going to have broader shoulders, a bigger chest. That can get stuck behind the pubic bone during birth. Now, inside the baby, things are getting bigger too. All that extra insulin is encouraging growth of organs like the liver and the heart, and that increases oxygen demand. Over time, babies' high insulin and therefore high oxygen needs, it is possible in the worst case scenario for those oxygen needs to outstrip what the placenta can supply when that gestational diabetes is poorly controlled. And then that can lead to fetal hypoxia. Baby's gotten too big, their organs are demanding more oxygen, we can't give it. Their oxygen goes down, fetal hypoxia, which worst case scenario could result in a stillbirth. Now let's think about what happens right after delivery, though. We clamp the cord, and all of that glucose rich blood from mom stops instantly. We are just cutting off baby's supply of glucose cold turkey. But their body got really used to pumping out a ton of insulin. So suddenly glucose is gone, but we're still making insulin. And that mismatch, of course, is going to lead to a low blood sugar, neonatal hypoglycemia in the first few hours after birth. Okay. So prenatally, uncontrolled high blood sugar, big baby, delivery complications. We cut off the sugar supply after delivery. Boom, blood sugar drops. That's going to be the biggest thing you as a nurse monitor for. So to sum it up, placenta, it's cranking out hormones that cause mom to become insulin resistant. The pancreas either can't keep up or the resistance is too intense. Glucose levels rise. Extra glucose crosses over to baby, and baby therefore makes more insulin. That combo means very well fed baby that gets very big, and that possibly can cause delivery complications. And after we cut their sugar supply, they become hypoglycemic after birth. So, what are we going to do? Our nursing care is about interrupting that cycle by trying to keep mom's blood sugar as close to normal as possible. And with that being said, let's roll into a case study to really look at how this plays out. And to go into this case study, we have the expert here with us today, Dr. Jennifer Bonner, a certified nurse midwife who has treated a lot of gestational diabetes. And we are so excited to have your insight on this case today, Jennifer.
Hey, Morgan, thanks for having me. I'm really excited about this one.
Awesome. Well, go ahead and tell us about your client with gestational diabetes.
Okay, so I had a 38-year-old female who came into triage and said, "Hey, haven't felt my baby move in probably a day or so." So big red flags already. So the first thing we did was, well, what do you think the first thing we do? We go ahead, we put him on the monitor, we check mom, we want to see, hey, what's going on here? And so anytime someone comes in and they're concerned about fetal movement, the first thing I want to do is reassure them by getting some heart tones of some sort. So we get mom hooked up to the monitor and we can't find any heart tones. And so our mind starts going, okay, maybe it's just a body habitus situation. She did have a higher BMI. She was an older mama. So there's just a bunch of things going through our head. So
Right.
we go ahead and we call our friends down in the ultrasound room to come do an ultrasound. And we find that there are no heart tones. So we start looking at What's going on? So we start drawing some labs, going through the things, after we've gone through the plan, and we find that her blood sugar, her just random blood sugar, is over 500.
Wow, over 500, super hyperglycemic.
Right. So we start asking, hey, is this normal for you? And she says, well, I don't really know. So from a nurse's perspective, we're going, what do you mean? What do you mean you don't know? Have you ever had, do you have diabetes, gestational diabetes? What's going on? And she tells us, I don't know. It's been a long time since I've been to the doctor's office.
Oh, wow. So
So
not
my next
consistent prenatal care.
No. So my next question is, okay, well, when was the last time you remember being
Yeah.
seen in the office? And she says, well, I know I had that first ultrasound,
Yeah.
and that was all she had.
And
So
that was
we
it.
go
And how far
looking.
along is she or about?
So at this point, she's 38 weeks.
She's 30. She's
So
full
she's
term.
term.
Yeah.
Yes, very, very much term. So at this point, there's a lot of emotions that are going on. There's a
Yeah.
lot of
Big
thought
time.
processes that are going on. And so we start having this conversation, and come to find out, she had been in for her 28-week labs,
Oh,
but they could never get a hold of her.
gotcha.
So we didn't have a whole lot of information to go on. She's just kind of explaining things. So when we think about gestational diabetes, typically we think about, the just prudent management. What can we
Yeah.
do that doesn't involve medication? And a lot of times, the first things that we recommend are diet and exercise, right?
Right.
We want to see, can we manage things without going to the extremes? If
Right,
we think
right.
about it
Because
like,
if we think about what's going on there, we've got a placenta, a new organ that's developed, producing a whole bunch of different hormones. And in general, those hormones are going to increase the resistance to insulin in the mother's body. So then what does that do to the baby? How does the baby respond? And obviously, in our case here, we have the worst case scenario, but there's a lot that can happen before that, and then there's a lot we can do to manage it to prevent that worst case scenario.
sure. So ideally, when she came in for those 28-week labs, we're able to see that the elevated 1 hour. And
Right?
there were a couple other things that were red flags. So we see that her BMI is higher. So, and ideally, we could have even done like a early
Right.
glucose tolerance test to see if we could catch it
Yeah.
faster, or sooner rather than later. And so when we see that elevated 1 hour, we go ahead and send them for what every mom is really hoping for to hear. I get to do a 3 hour test. And it just means that you get to be best buddies with your lab specialist, with the lab tech, because you're going to be with them for a little bit.
For 3 hours. And really quick before you move on, can you talk us through the 1 hour and the 3 hour glucose tolerance test? What's the provider looking for? What does the nurse need to know? Because it sounds like that's where things went wrong for this mama is, maybe she did or didn't have this screen, but then didn't have follow up from there.
Right. So the 1 hour glucose tolerance test is pretty much our average screen. Just about everybody is going to receive that or have it at least scheduled. And so unless somebody is already diabetic, typically we're going to send them
Uh-huh.
for this test. And so what happens is they don't need to be fasting for the 1 hour. They're going to go ahead, they get this little cute little bottle of beverage. It comes in all different colors and flavors, from um, lime to orange, fruit punch, all the things. And so they go ahead and they drink this. And then 1 hour later, we check their blood sugar. And if that blood sugar is elevated, then we send them on for the 3 hour test.
Right.
They do not do these tests on the same day. And here's why. So remember, I said the 1 hour you don't have to fast for, but the 3 hour, you have to do a fasting blood sugar with that one. And so once I became a midwife, I thought, you know what? I've never had gestational diabetes. At that point, I could say I had never had gestational diabetes. But you know what? I don't really like to feel hungry. I don't like to feel my stomach rumbling. So I would always send my women to the clinic first thing in the morning so they could be
Right.
fasting all night and then they
Yes.
get to the lab first thing in the morning. They can draw that fasting blood sugar. And then
Yes.
they give them another lovely, cute little bottle of beverage, but this time it has 100 grams instead of the 50 grams of sugar that it had in the 1 hour.
Right.
So they go ahead, they drink this, then we check their blood sugar at 1 hour after, 2 hours after, and 3 hours after.
Right.
And so, as providers, as nurses, what we're looking for is if that fasting blood sugar is elevated, we diagnose them with gestational diabetes. Or if two or more of the other lab values are elevated, then we diagnose them with gestational diabetes.
So we're looking to see, how does that mother's body handle the glucose load? Is she able to take that 50 or 100 grams of glucose, make enough insulin, and have that insulin be received by the body so that we can scoot that glucose into the cells and not keep it just all sitting in the bloodstream? Because whatever is in mama's bloodstream is basically the amount of sugar that baby's going to have. Glucose goes across that placenta nice and easy, insulin not so much. So the glucose is going to go, the baby's going to be very well fed. And then what do we see with the baby from there?
So it's really great because babies are doing what they're designed to do. So moms are saying, here, baby, have all of this glucose, right? And so the baby says, okay, I have all of this glucose. So what does my pancreas need to do? It needs to produce
Make
insulin to take
insulin.
care of that, which is great. That's exactly what we want it to do. But the problem is once that baby is delivered, it still has all that stored up insulin, but it doesn't have all that glucose that mom has been feeding it this whole
We kind
time.
of
And it
cut them
goes,
off cold turkey there when we cut
I
the
know.
cord.
It reminds me of this year when I took my kids to an Easter egg hunt and they put all these eggs out on the floor. And so we have all these kids, but the big kids had come and taken the majority of them. So you
Oh
have all these
no.
kids and there's no eggs. So that's kind of what's happening here is you have
Yeah.
all this insulin, but not enough glucose
Right.
for the insulin to attach to. And so
Right.
that's why we see a lot of times hypoglycemia
Yes.
in newborns. And so that's why as nurses, we want to be checking those blood sugars in between feedings to making sure that baby is able to hold on to a stable blood sugar.
Yes, that is like the big takeaway that I remember from school was, the babies are generally born on the bigger side because they've been really well fed. They've had this sugar, but then when we cut them off cold turkey, their blood sugar tends to go down. So we really watch for low blood sugars in babies born to mothers who have gestational diabetes.
Mhm. It's true. And it's really interesting because when we think about all the things that can occur in gestational diabetes, we know that some of those are bigger babies, macrosomic babies, babies that are bigger than 9 pounds. And so we see that, and there's a lot of issues that can occur with that, right? When we're having delivery, that baby is at risk for one of the scariest things that can occur, which is shoulder dystocia, where their
Mhm.
shoulder gets stuck underneath that maternal pelvis and we can't get them out. And that's really scary. So we put mom in all these different positions to try to get that baby
Yeah.
out. So that's one of those things. The other thing is, I was just talking this morning during a live lecture about labor and delivery, and we were talking about what are the things that increases someone's risk of postpartum hemorrhage and really anything that's going to overexpand the uterus. So
Yeah.
we know that just in normal pregnancy, the uterus is expanding, right? It's getting bigger to accommodate that baby. But if there's too much of something in there, it can overexpand.
Yeah.
So, like polyhydramnios, macrosomia, like we see with gestational diabetes, and that can put our mamas at risk for postpartum hemorrhage.
Right.
And so, in this case, we're going through the background with this client, trying to figure out where did we go wrong, but we also have this very real situation where we need to take care of what's going on. And so we talked
Right.
to her about, hey, here's the options. We can induce labor, we could do a C-section. This mama had had two previous C-sections before, so a repeat sounded the best to her,
The best
and the
option.
safest to her. But sometimes as nurses, we forget that it's not just vaginal deliveries that are at risk for postpartum hemorrhage.
Right.
We also had a C-section for this lady. And lo and behold, postpartum, she's dealing with the grief of this lost child, and she has a postpartum hemorrhage. It
Oh
was
my
just a
goodness.
culmination of a series of unfortunate events. But
Yeah.
when we start to think about, hey, we have this, we know this baby is rather large because on ultrasound it showed us. I believe the baby ended up being 12 to 13 pounds. It was fairly big,
Yeah.
especially for this mama. She had not had very large babies to begin with. And so the fact that she had a macrosomic baby put her at
Yeah.
risk. The
Yeah.
gestational diabetes put her at risk for all of these
Yeah.
things. And so when we start to think about that, we need to prepare for, okay, we see all these red flags, just like we talk about with clinical judgment. We're starting to analyze the cues and thinking about, okay, what do we need to be ready for? And one of those things is we need to be ready for a postpartum hemorrhage, whether that's a C-section or a vaginal delivery.
I love it. I love it. So, baby, we're worried about low blood sugar. Mom, we're worried about postpartum hemorrhage. If she's been really, really stretched, that's one of those risk factors. And when we have too much glucose, baby making too much insulin, they can grow too big. So, that macrosomic fetus can put her at risk for postpartum hemorrhage. Amazing.
Right.
Not
And most
amazing
of the
for
time,
mom, but
not amazing. But most of the time, postpartum, mom's gestational diabetes goes away. We do like to bring her back postpartum to do another glucose tolerance test, this time at 75 grams of sugar, and we check her blood sugars afterwards. But typically, that diabetes does go away, but it does put her at risk for diabetes later on in her life.
great. So when counseling mothers postpartum after having gestational diabetes, what advice do we give them? How does that management look ongoing? If they're at higher risk, do they need to have screening, blood sugar checks, diet and exercise? What are we looking at for our nursing education for these moms?
Sure. So, as a midwife, I am all about empowering women to take control of their health and to do what they can to be there for themselves, but also for their families.
Yeah,
So a lot of times what I would recommend is just seeing your doctor, your midwife, your nurse practitioner for your yearly checkups, getting those labs drawn. You are at risk for diabetes later on. So keeping an eye on
yeah,
those things. But if I know that I am at risk. Let's say I know that right now it is 30 below outside. Before I walk out my door, what am I going to do? I'm going to get on my hat. I'm going to get
yeah,
on my gloves. I'm going to get on my really fuzzy Eskimo coat. I'm going to prepare for those things, right? So, because I would be at risk for frostbite, for frozen, all the things. Now, when I know that I'm at risk for diabetes, then I want to prepare for those things. So, what can I do to decrease that risk? Well, I can add in some exercise, even as little as just 30 minutes a day, brisk walk. Listen, when you have small children in your home, just like I do right now, it's like every day is exercise because you're running up and down the
you're
stairs,
keeping up
back and
with them.
forth. Get down from there, don't touch that, things like that. So just a little bit of exercise is really helpful. Keeping those sugary treats, and I say this knowing that in where we're at right now, there's a lot of sugary things going on, but it's okay to have those in moderation. But if we can pair those sugary things with a protein, a lot
Uh-huh.
of times that will help bring down our blood glucose. But
Yeah.
just being mindful of what we're eating, what we're fueling our body with. Those proteins like chicken breast, things like that are really helpful. Fruits and vegetables are great. And then, making sure that we're adding in that exercise is going to be key there. So encouraging her on, hey, here's the risk factors. So we want to present reality. What's
Yep.
happening? What are you at risk for? But also, like, all is not lost. It's not this terrible thing, but here's
Yeah.
some things you can do to decrease that risk going forward.
Amazing. All right. Well, thank you. That was a obviously very scary and worst case scenario. case for you to walk us through. I think it was excellent for us to hear really from beginning to end how that was managed, what nursing priorities we looked at, and of course, looking forward into how we can prevent and educate those mothers long term. So, thank you so much for joining to share your expertise about gestational diabetes and everything we can do to prevent, manage, and educate our clients.
Thanks for having me, Morgan. This was so much fun.
All right, now that we've gone through that story with Jennifer, it is time to circle back to our original question and see if you can get to the right answer and understand why. Remember, you are teaching a 30-year-old client at 28 weeks gestation who was just diagnosed with gestational diabetes. Which statement shows a correct understanding of the teaching? We had A, once I deliver the baby, I won't ever need to check my blood sugar again. B, keeping my blood sugar in the target range can help prevent my baby from getting too big and having low blood sugar after birth. C, I should avoid exercise during pregnancy so my blood sugar doesn't drop too low. Or D, because I have gestational diabetes, my baby will probably be small and need extra growth scans. Think it through. Which of those indicate the client understands your teaching about gestational diabetes? If you said B, keeping that blood sugar in the target range, you are correct. That correctly demonstrates that mom understood the core pathophysiology. Glucose crosses the placenta and drives that high insulin from baby. That makes the baby grow big. And when we cut off their sugar supply by clamping the cord after birth, their sugar can drop. So all of that treatment we talked about with Jennifer was all about keeping the blood sugar in the normal range so that the baby doesn't get too big and that after birth, we don't have a massive crash leading to complications. Option A, after I deliver the baby, I won't need to check my sugar again. That is incorrect. Gestational diabetes doesn't just vanish once the placenta is delivered. Most women will see their sugars normalize, but there is a lifetime risk of developing type 2 diabetes, and they will absolutely need follow-up screening and long-term prevention. Quick test-taking tip, if you ever see absolutes in an answer choice, like I won't ever need to do that ever again, most of the time, that's the wrong answer. Never and always, I would avoid picking those answers. Answer choice C was incorrect because light to moderate exercise is actually going to help lower blood glucose, improve insulin sensitivity, and be protective against gestational diabetes. We are not telling clients with gestational diabetes, hey, don't go exercise. We just need it to be safe. And lastly, D, my baby will probably be small and need extra growth scans, we know is incorrect. That baby is more likely to be big because they are getting more insulin and more glucose, and those are fueling their growth. So your key takeaway for this episode for gestational diabetes is that it's really all about the placenta. Those hormones the placenta is making increase insulin resistance. Therefore, mom has to make more and more insulin. And when we can't keep up, that glucose gets high. Whatever is in mom's blood goes to baby too. So a baby with lots of glucose makes lots of insulin themselves. They grow really big, and they are therefore then at risk for hypoglycemia after birth. Your job is to help keep mom's blood sugar in normal range and very closely monitor that baby for delivery complications and neonatal hypoglycemia. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.